YouTube. Hi guys. It's Dr. Becker, and this week I have decided to do my video about dizziness. I was gonna do stuffy nose because it's a good time of year for stuffy nose. It's a lot of allergies and stuff right now, but then I decided after seeing a bunch of patients in the office this week with dizziness that I wanted to talk about that a little bit today. So first I want to talk about the difference between dizziness and vertigo, and then I want to talk about the ways in which ENT doctors understand vertigo and dizziness and what sort of how we separate things out in our minds. And then I want to talk a little bit about the treatment of different types of dizziness and vertigo, so that if this is something that plagues you or a loved one or a friend, hopefully you can understand more about it and what you can do about it. So first of all, I'll just get started with a story. About 2 years ago, I was laying in bed and I rolled over onto my left side, and all of a sudden the room started spinning around. I felt like somebody had just put me on a merry-go-round and I was just spinning in a circle like this. And it startled me, and I waited about, it seemed like a long time, but it was probably 5 or 10 seconds, and then it stopped. And I knew exactly and immediately what was wrong with me. And I knew this because I'm an ENT doctor and I'm familiar with this problem. It's the most common cause of vertigo. It's called benign positional vertigo. And if you've ever had the experience of rolling over in bed and having a sudden spinning sensation, then that is also what you've had. It's almost a 100% accurate question that if somebody has the symptom of rolling in bed, they're fine, they roll over in bed and they get the symptom, that's almost always the diagnosis. It's like kind of a cool question like that. But anyway, so I said, okay, I have this problem. I know what to do about it. And I, went and tried to do some maneuvers on myself, which I'll talk about later. And of course, it was a complete disaster. Even though I know exactly what this is and I know how to do the maneuvers, I was trying to do them without anybody helping me. And honestly, I just made it worse. It was terrible. And I know sometimes patients can do this. They can figure out how to do it by themselves. But I guess the moral of my story is that when it comes to dizziness, you should get some help from an expert. And if there's anything that we take home today, like a take-home message, I think that's what it's going to be. So first, let's talk about what is dizziness and what is vertigo. Because people say, well, do I have vertigo? And I say, I don't know, do you? Because what vertigo is it's really a symptom. It's like saying I have a runny nose. If vertigo all by itself, the word vertigo is not a diagnosis. It's just a description of something that happens to you. So vertigo is the feeling of spinning or sometimes extreme motion when you're not spinning or having extreme motion. So it is it's associated with a lot of different types of problems. And if you have the sensation of spinning, then you have vertigo, whether it lasts for a few seconds or an hour or longer. So it's not really a diagnosis. We also talk about the symptom called dizziness, which is, we make a distinction from vertigo because vertigo is really that feeling of spinning or motion. But dizziness can include a lot of other sensations too, feelings of being lightheaded, feelings of being wobbly or imbalanced, feelings of being out of body or sort of floaty headed, and feelings like you're about to pass out are all kind of fall in the dizziness category and aren't necessarily the same thing as vertigo. And really, when I talk to patients about these problems, I don't really even want the patients to label them. I don't want them to give them a name. I really want to know what is happening in your words. So, for instance, people will come in and say, well, I have vertigo. And I say, okay, well, what exactly happens? When did it happen? When did it first start? How long did it last? could you walk, or did you like fall down and throw up, or was it more like just like, I don't feel well, I want to sit down, or maybe you just like didn't feel well, but you just kept going through the grocery store anyway? There's a lot of things in the history of someone's vertigo experience, in their story, that are really, really important in making a diagnosis when it comes to these symptoms of vertigo and dizziness. In fact, I'm going to say that probably a skilled practitioner who's really familiar with this problem can probably make a pretty accurate diagnosis of the likely causes of vertigo from history alone, just from a careful discussion. It's one of the reasons why when someone's evaluating you for vertigo, they should really listen to you and to what exactly you're feeling and what are the things that set it off or come along with the feelings, or and also the quality of the feeling and how long it lasts and how severe it is and things like that. So the history is super, super important. I will give you an example of maybe say 5 of the most common causes of vertigo, and I'm going to explain to you how they're extremely different. First, I'm going to talk about the problem that I had, which is called benign positional vertigo, or really properly benign paroxysmal positional vertigo. So we call it BPPV for benign paroxysmal positional vertigo. And that is a diagnosis, okay? That is a specific symptom that's caused by the crystals in the inner ear, which are normally responsible for telling our brain where our head is going. One of those crystals becomes loose from the little sensors that it's normally stuck on that give the message, and it floats around inside our inner ear and bangs up against other sensors, which are responsible for telling our brain that our head is going in a circle. So when it hits the wrong sensor, our brain says, we're going in a circle, we're going in a circle, we're going in a circle. And so it gives us this impression that we're going in a circle. Now that particular problem is usually manifest by discrete, brief episodes of vertigo that are brought on specifically by a change in the relationship of your head to the ground. So they won't be they won't be caused necessarily by someone sitting in a chair and then standing up, right? Because your head is straight. But when you're lying in your bed and you turn over, that really changes your head position. And that will be a trigger for you. So but in between, like if you're just sitting watching TV and you're not moving at all, most of the time, the dizziness sensation will not be there. So that can happen. It can start and it can happen every time you turn your head. And in that way, it can last for days. But it's sort of a few days of many people are very functional. They just don't want to move their head in any sort of way because they'll get dizzy. Sometimes people with BPPV do have a baseline level of like wooziness and inability to function, but it's usually not to the level of like can't walk or vomiting or something like that. Usually those people, the crystal's really close to that other sensor, so really anything that they do sort of sets them off. But that's an example of a very, very characteristic history where if someone tells me that, I go, well, I think I kind of know what you have. There's other vertigos that are also based in your ear that are very different. Some people say, well, I've read about Menieres disease or a viral labyrinthitis. Could it be something like that? And I really say, those just walk into the room completely differently. Someone who's had a viral attack or their first episode of Menieres, which by the way, those two things do look similar, will have a sudden onset of a violent vertigo that lasts for hours. And most people, even those who don't tend to get motion sick, will get so motion sick from that experience that they will experience nausea, sweating, vomiting. Oftentimes they can't walk. They crawl to the phone and call 911 or call their loved one to come and help them. It's a very, very intense experience that lasts for hours to sometimes days, and it'll come on very strong, and then it will slowly ebb over the course of hours to days, and even leave people feeling a little off sometimes for days to even weeks after that if it was a severe viral attack on the ear. So that's a completely different story than every time I turn my head this way, I feel spinny, right? Now, the virus and Menieres start out the same way, but the difference is the viral attack will only happen once. experience tends to be longer. Whereas Menieres disease will happen, you'll have that experience, violent spinning, very yucky, awful experience, and then it'll go away, but then 3 weeks later, it'll happen again. So then we know, no, it's not the virus coming back, it's something else that's wrong with the inner ear. Now there's 2 other things that are the other 2 most common causes of dizziness, again, with completely different stories. The other ones that I want to talk about are the sort of migraine associated, or we call it migraine phenomenon or migraine variant vertigos, and also the category of vertigos we call persistent subjective vertigos, which are a very interesting problem and probably related a little bit to anxiety or maybe depression. Kind of so migraine, they're all kind of a little bit like a brain-centered problems, the other 2. Now, the migraine-associated vertigo, or what we call headache-associated vertigo, is really a misnomer because it's sometimes not associated with headache at all. Sometimes it is. Sometimes it just happens in a time when people's headaches are active. So they're sort of getting a lot of headaches nowadays, and a lot of us who have headache, we're familiar with that, where we'll get into a phase where we're like, why am I getting all these headaches? And it's a really good question to ask because the treatment for the headache-associated dizziness is to try to reduce the migraines and the headaches, and that will also reduce this other weird side effect that our brains seem to get. Sometimes we will get dizzy with a headache, and we'll get spinny and nauseous and off balance, and sometimes we'll get little waves of like, whoa, oh, I felt something weird. I just turned the corner and it was really strange. I just had to catch up with myself kind of thing, multiple times during the day. So considering the sort of the migraine phenomenon is really important in your differential diagnosis of why you're feeling dizzy. And again, that story is completely different because those people will come in and say, oh no, I get this. It's just a little weird wave and I don't even have to tell anybody else that it's happening to me and they might not necessarily notice. So that's a very different one. Same with the persistent perceptual vertigos. And we may, as we learn more about that whole category, understand that they're related to each other. But those are all also usually very vague, sometimes quite chronic. People have been struggling with them for months to years. And that category of vertigos that are not as discrete as the first 3 that I described really probably are what we call central vertigos. So they're not really coming from the ear itself. They may have started out with an ear problem like the BPPV or maybe a virus or something, but the way the dizziness is continuing cannot be coming from the ear itself. It has to be coming with some problem with putting all the information from the ears and eyes and neck and body together inside the brain. That's where the problem is. So you can see that all these stories are very, very different. And getting to the right diagnosis and understanding of, is this an ear problem? Is this a brain problem? Is very important in the treatment. So that is my segue to talking a little bit about the treatment of dizziness. First of all, most people who go to, their initial, doctor or like urgent care or ER for dizziness will get a prescription for a medication called Meclizine. Meclizine is also known as Bonine. It's over the counter as a motion sickness pill, 25 milligrams. And it can be very helpful acutely when you're feeling dizziness or vertigo. What it does is it sort of numbs the vestibular system. So any of that feeling of things not fitting together is going to be reduced. It's a little bit like taking a Tylenol when you have pain. The problem with Meclizine is it does make you sleepy, and it really doesn't fix the problem. It doesn't fix it at all. So all it is a symptomatic treatment for when you're feeling very uncomfortably dizzy. And sometimes you can go take a nap, and if it's a migraine type vertigo, then that will actually make you better. But it's the sleep that's making you better, not the Meclizine. So, the other problem with Meclizine, aside from that it doesn't actually like cure you at all, is that it will interfere with the long-term compensation that your brain needs to do if you've had an injury to your ear. So for instance, if you've had a viral labyrinthitis and you're trying to recover from that, taking Meclizine will actually make it harder for you to recover and sometimes keep your symptoms around longer. So you don't want to take it unless you really need it to feel comfortable. So that's the thing about Meclizine. And the second thing I wanted to say about treatment, and I'll share a story about this too. I was talking to a patient this week, maybe part of my inspiration for doing this video. And I said, well, I really think that we should get one of our vestibular therapists involved. Now, most people haven't heard of a vestibular therapist, but what they are, they're physical therapists who have special training in balance and dizziness disorders. And most of them are quite knowledgeable about the way that our balance system works, the way our ears work, but also the way our brain works to put all the information together from the rest of our body. And they are a big part in my practice of helping figure out where the actual problem is and also helping to actually get patients better. And so I told this patient, well, I think we should get the vestibular therapist involved to help us suss out, some of the balance issues that you have. And she said, well, I don't agree with you. I don't know what these therapists are, and I don't think that I need to go to a therapist. And it kind of made me realize that I take for granted what I know about vestibular therapy and how valuable it is, and how they're kind of like this little niche of physical therapy that a lot of people have never heard of. So I'm telling you right now that you've now heard of them, and they're pretty great. So the vestibular therapists are a huge part of getting you better, because if any of the things that I mentioned, whether it's BPPV and you need an adjustment for the ear crystal, whether it's a viral illness and your brain needs to sort of heal the connections with your ear and recompensate for any type of injury that may happen, if it's Menieres disease and you need to have further education about that and understand, again, how to compensate with any changes in your vestibular organ, if it's migraine, if it's persistent postural vertigo, those are all conditions that the physical therapists help us to treat. So the PT visit is extremely helpful if you're having any kind of dizziness or imbalance, but it is also helpful, of course, to talk to an ENT doctor that understands this sort of gamut of the dizziness experience as well. So, and finally, I sort of want to say that the other tool in your kit for trying to figure out your dizziness problem is actually the neurologists, because the ear, of course, has the balance organ in it, and that tells your brain information about whether or not your head is tilted or moving. But in the end, it's your brain that puts everything together, right? So if you're having a problem with synthesizing information, the neurologist may want to check certain brain functions and can be helpful, for instance, with treating things like migrainous vertigo or headache-associated vertigo by working on that fussy brain inflammation that causes the symptom in the first place. The neurologist can also dabble a little bit, aside from in headache prevention. They can also, sometimes prescribe medications like the SSRIs, which are like the Zoloft, Lexapro, Prozac, Celexa kind of category for people who have persistent perceptual vertigo, which again, we don't entirely know if that's really like related to anxiety or depression somewhere in the brain, or whether it's related to migraine, because all these problems are serotonin problems and these medications boost serotonin in our brain. But we do know that for some people with chronic perceptual vertigo, the SSRI medications actually can be helpful, even if those people tell us, well, I don't think that I'm anxious or depressed. But if the symptom is prominent enough, it's probably worth exploring that option. So those are the big categories for the dizziness problems that most people have, and a brief summary, so brief, of how we treat those various things. So thanks for listening to my dizziness introduction. And again, I just encourage you to talk with an ENT who's very familiar with balance and dizziness problems, and also talk to a physical therapist who has a specialty in vestibular therapy if you're struggling with any dizziness issues, and watch that Meclizine. Okay? All right. Well, it's great to see you this week, and I'll see you next week on Ask the ENT. Bye.